There's a variety of different ways that we define severe glaucoma. Many of us use different grading scales. The Hodat-Parrish-Anderson is one of them. CIGIT's, the Collaborative Initial Glaucoma Treatment Study, taught us another one. Medicare uses a specific one when we're documenting or thinking about severe glaucoma. And what they say is optic nerve head abnormalities consistent with glaucoma, as well as retinal nerve fiber layer changes, along with glaucomatous visual field changes in both hemifields and or vision loss in the central 5 degrees of fixation in at least one hemifield. And so it's probably worth reviewing one of those 3 different classification systems so that we're documenting appropriately when we're defining what severe glaucoma is. I think our glaucoma landmark studies still are very helpful. Yes, they're a bit dated, but they help us to still make decisions. They help us go down the right track when we're managing patients. It's no different when we're talking about severe glaucoma. The CIGIT's trial, for example, the one we just talked about, looking at advanced disease or late stage disease, said that visual fields were better preserved in these advanced patients if the initial treatment was a trabeculotomy. The AEGIS study, the Advanced Glaucoma Intervention Study, looked at a variety of patients that had 100% IOP less than 18 were less likely to progress on their visual field than a group of patients that were less than 18 50% of the time. And so that tells us if we can keep our advanced patients, our severe glaucoma patients under 18 and do it consistently, we have a better chance of at least slowing down progression. And then we have some treatment studies. The primary tube versus trab study, which I'll touch on here in a second, and then the 5-year tube versus trab study, which showed that both are very efficacious, trabeculotomies being a little bit more effective than tubes. But we also found out with these 2 procedures that there's some complication rates and some failure rates. When we look at those percentages, we know that 30% of the time tubes failed and nearly 50% of the time trabs failed at 5 years. When we look at their complication rates, there was a 39% complication rate with tubes. There's about a 60% complication rate with trabs. The newer 3-year study, primary tube versus trab study, has showed us that really right now, currently, there's no significant difference in the rates of surgical success between the 2 procedures.